medevac hierarchy is a hierarchy that measures the least risk to most risk in terms of evacuation and care of a patient. The first choice is to pull the cruise ship into port and do a transport shoreside with a receiving EMS component. The second is to divert to a vessel that has a competent doctor on board, preferably an amber vessel. This way, a level of care can be maintained or elevated. The third portion of the hierarchy is transferred to a Coast Guard vessel with a medical component on board. The fourth is to do a small boat transfer, and the fifth most risk evolution is a helicopter hoist. A medevac checklist is a set of procedures and tasks that a watchstander will fill out. In the watch construct, there are many people that are involved in its development. This check sheet is filled out and used as a tool to brief a Coast Guard flight surgeon. The sooner we get the information, the better it is for us to execute a safe and orderly mission. The authorization from a medevac is processed and discussed and deliberated on all levels of the search and rescue chain of command. Risk is discussed, the operational constraints are discussed, the medical well-being of the patient is discussed, and how we're going to meet those requirements set forth by the medical protocols. Operationally speaking, we move to meet those requirements, but we are a very close step with the flight surgeon and what he or she is recommended to us.
From the standpoint of the flight surgeon, a medevac entails providing a risk versus gain assessment to the operational command. When we get a call regarding a medevac from a cruise ship, we need to be able to assess the degree of medical necessity for such an evacuation. Because of the risk involved, usually the standard that we judge these cases by is there an imminent risk to life, limb, or eyesight, or is there significant human suffering that can be alleviated by doing the transport. In order to determine what the medical gain might be, we generally are going to want to speak directly to the medical staff on the cruise ship. And the sort of things we're going to want to know are, what does the patient have? What do they need that can't be provided on the cruise ship? And when do they need it? In what time frame? And where can they get it? Do they have a plan for where they think they can send this patient in order to get the higher level of care that they feel they need? And ultimately, can we meet that window of opportunity? Are we going to be able to do this operation within the time frame that's actually a benefit to the patient? We have rescue swimmers who are trained to the level of basic EMTs who can assist, who will assist in the packaging and loading and basic medical care of the patient en route. But if there's any higher level of medical care that's needed other than basic level EMT care, that care will need to be provided by a member of the cruise ship medical team, will need to accompany the patient. We do not provide in specialized medical equipment. All that needs to be provided by the cruise ship, and any electrical equipment that they want to send along with the patient needs to be battery operated and approved for use in flight.
Hi, my name is Steve Williams. I'm Team Commander with the Florida Advanced Surgical and Transport Team. I've been a flight nurse for over 25 years, and during that time I've done hundreds of critical patient medevacs, both in medical helicopters and in US Coast Guard helicopters. I've also spent the last 16 years working in the cruise industry, initially at Carnival Cruise Lines and then at Royal Caribbean. What we're going to do today is talk about some of the patient care issues associated with a patient medevac at sea by helicopter. You heard from Captain Mark Scheffler earlier on that when the Coast Guard is requested to do a medevac at sea by helicopter, they're going to conduct a thorough and detailed risk assessment. If you're the physician that is making the request for a medevac at sea, you have to be absolutely convinced that the request is appropriate, that the patient will survive the trip, and that you're not putting a helicopter crew and the patient at risk to evacuate a patient unnecessarily. So during that initial evaluation, the Coast Guard is going to want to know what is the gain to the patient by doing this medevac. And in doing that, they're trying to ensure that the risk of the flight is appropriate given the patient's condition. As the physician making the request for the medevac at sea by helicopter, you are medically, legally responsible for the patient until the patient reaches the hospital. So it's very important for you to make sure that the patient is going to survive. I know of multiple cases of patients where they were flown by helicopter and died, and it's entirely conceivable that had they remained on the ship, being looked after in the medical center on the ship, then they wouldn't have died. If you're requesting a helicopter at sea, you need to ensure that you're sending a physician or a nurse, because it's appropriate to continue the level of care that you've provided in the medical center. And if you're going to be accompanying a patient in a Coast Guard helicopter, you need to be wearing some sort of life jacket. And the type of life jacket you should be using would be one like this, which is a manually inflating life jacket. You shouldn't be wearing one of these Stearns vest type buoyancy aids, because this will inhibit your egress from the aircraft if it goes down in the water. This will facilitate it. So always remember you should be wearing a manually inflating life vest, not one of these Stearns vests. So let's briefly review the type of patients for whom requesting a helicopter medevac at sea is really not appropriate. I think I'd like to start with nighttime operations. For those of you that are managing a patient at night, you need to appreciate that helicopter evacs done at night are inherently more risky. And I think it's true to say that there are very rarely a clinical scenario that justifies medevacing a patient at night because of the risk to the crew, the helicopter, and the patient. The other groups of patients who typically do not do well in a helicopter are those patients who are immediately post-cardiac arrest, those patients who are in respiratory failure, perhaps with congestive heart failure and pulmonary edema, because they're going to be lying flat in the aircraft. The other types of patients that don't do well are those patients who are hemodynamically compromised, particularly those patients who are hemodynamically compromised because of an acute GI bleed. Those patients with an acute GI bleed who fly by helicopter generally tend to do poorly, and we think that their bleeding increases by virtue of the increased motion during the flight and the low-level vibration, which possibly causes their bleeding to increase. Patients who are hemodynamically compromised because of an acute blood loss, particularly from a GI bleed, really need whole fresh blood transfusion before any attempt is made at medevac by helicopter. If your cruise line does not offer whole fresh blood transfusion, this is a life-saving option that I would encourage you to explore with the cruise line. So in summary then, patients who are hemodynamically compromised or patients who are immediately post-cardiac arrest are really not good patients to go in a helicopter during a medevac. I want to make a few comments about airway protection. If the patient that you're evacuating is unconscious, then they need to be intubated. Very few cruise line patients have not had something to eat or drink in the hours before their medical emergency. And as you saw in the video, it's not uncommon for the stretcher to actually spin as it goes up into the aircraft because of the wind on the stretcher. That movement of an unconscious patient inside a stretcher that's spinning will induce vomiting. I know of one case of a 32-year-old man who was on a cruise ship, took a benzodiazepine overdose, was unconscious, a helicopter was called, the patient was not intubated, his airway was not protected. In the hoist, during the hoist on the way up to the helicopter, the patient apparently vomited and aspirated, and the medic in the helicopter was unable to intubate or resuscitate the patient, and the patient died. Now that patient died because his airway was not protected. If that patient had stayed on the cruise ship with a benzodiazepine overdose, the patient would have survived. When transporting a patient who's intubated by helicopter, it's critical to ensure that the ventilator that you are using has been approved for flight in the helicopter in which you're flying. Most of the cruise lines use the Univent 731 or the Univent 754. This is the Univent 754, and both of these ventilators, now manufactured by Zoll, the Univent 754 and the 731, have been approved for use in a Coast Guard helicopter. It's also important to ensure that your ventilator hose is not kinked or partially obstructed by the straps on the patient. And another very important point is to ensure that the ET tube is secured appropriately with a securing device rather than just tape. This tube, as you all understand, is critical. If this tube comes out during the hoist or in the helicopter, it's going to be almost impossible to re-intubate the patient. So it's absolutely critical that you have an appropriate securing device for your ET tube. The other thing is the weight and balance of the stretcher. What's important to remember is as the stretcher is going up into the helicopter and being pulled into the cabin, if you have too much weight on the bottom end of the stretcher is going to tend to go into a head-up position, and that could be detrimental to the patient's hemodynamic status, and also you could lose some items. One of the things that we also recommend is that one of the securing straps for the patient's stretcher goes through the handle on the ventilator, so that there's no way that this ventilator can become dislodged during the hoist. The other thing is to remember that no Coast Guard helicopter should be assumed to have oxygen. When you're transporting a patient who's ventilated, you need to ensure that you have adequate oxygen for the duration of the flight and also possibly some of the ground transport time. Remembering that one E-tank for a patient on average, an average patient on average ventilator settings, one E-tank will last about 30 minutes. So you may well need to bring 2 or 3 E-tanks. I'd also recommend that you look at a system like quick connect hoses, which enable you to transfer the oxygen tank when it's empty quickly from the ventilator. So you just simply unplug the first tank that's now empty, and you attach the second tank using this. It saves you having to change out the regulators. The other thing that you need to make sure, obviously, is that your ambu bag is close to the patient, and it needs to be somewhere that you can get it in the back of the helicopter if it's poorly lit, or if the ventilator fails, you need to be able to get hold of the ambu bag quickly. And we usually recommend tucking it under the blanket just by the patient's head. So let's cover a couple of points about patient packaging. When the helicopter arrives above the ship, it's very important to ensure that the patient and the medical team are there at the helicopter hoisting point at least 5 to 10 minutes before the arrival of the helicopter. That's to minimize the time that the helicopter spends hovering over the ship. When the helicopter rescue swimmer comes down to the deck, they'll bring their own stretcher, because you're not going to be sending the patient on the stretcher from the ship. So it's important to have the patient prepared to transfer from your litter to the Coast Guard litter. Easiest to do it with a sheet underneath the patient, or perhaps if the patient will tolerate a backboard, then a backboard makes it actually much easier. So a couple of points about the stretchers. It's important to consider weight and balance of the stretcher as you and the rescue swimmer are packaging the patient. Remember, you need to be doing this rapidly, but it needs to be done with thought and care. Too much weight on the bottom of the stretcher will mean that as the aircraft hoists the stretcher up to the cabin of the helicopter and the flight mechanic pulls the stretcher in, you can get a very upward movement of the stretcher, and that may be not in the best interest of the patient. And you may also lose vital pieces of equipment with the stretcher at a tilt. So it's important to make sure that, particularly for the ventilator, that your patient securing strap goes through the handle of the ventilator. A word about ventilators. There's 2 ventilators that are most commonly used in the cruise industry. That's the Univent 731 and the Univent 754. Both those ventilators are approved for use in military or Navy type helicopters flown by the Coast Guard. But it's important to mention that point, obviously, to the flight surgeon when you do the initial brief. So the ventilator is secure. You need to secure the oxygen tank and make sure that that is in the right place and it will not fall out. In terms of oxygen, you should not assume that the Coast Guard has any oxygen, and so you need to calculate your oxygen consumption very carefully, understanding that an average adult on average ventilator settings will burn through an E-tank in about 30 minutes. So you may actually have to bring 2 or 3 E-tanks to cover the duration of the flight and also any possible ground transport time. Important to ensure that the straps over the patient don't kink or occlude the ventilator tube. And then we really do recommend paying special attention to the endotracheal tube and making sure that it's secured by an appropriately made commercial device. Don't just use surgical tape to secure the ET tube, because if this ET tube comes out, either during the hoist or in the back of the helicopter, it's going to be almost impossible to re-intubate the patient. So it's critical that the tube is adequately secured with one of these similar devices. The other thing that you need to bear in mind is that, as in any type of aviation involving medicine, everything can go wrong. A ventilator that's worked perfectly for 3 months suddenly stops working during the flight. You need to have your ambu bag or valve mask easily available, and we recommend putting that right next to the patient's head or under the shoulder so that you can get to it rapidly, particularly if you're in a dimly lit helicopter and you're having trouble finding it. This is the interior of an MH-65 Dauphin Coast Guard helicopter. If you call for a medevac, this is very likely the aircraft that will be responding. And as you can see, there's not much space here. This is the interior that you would be working in if you were trying to manage a cardiac arrest. The patient is managed on the floor. There's no room to sit the patient up. There's very little room to move. Your equipment's one side of the patient, your monitor's the other. So I use this as an example because this is the background to making a decision to evacuate a critical patient at sea by helicopter. And many times, the best place for that patient until the ship gets into port is actually on the ship in a well-lit, well-staffed, well-stocked medical center on the ship. So if you're making a decision to evacuate a patient by helicopter, you need to make sure that this patient will survive the flight and that the gain at the other end of the helicopter ride is appropriate for the patient.
By the time we get the notification, we will get off deck, take off within 30 minutes, and we'll plan as a crew what we need to bring with us. So we'll take into consideration the condition of the patient, and everything that we have to consider for getting that patient safely off the cruise ship. So we'll be talking to the flight surgeon, we'll be talking with our rescue swimmers and kind of collaborating as a crew. After we take off, while we're en route to the case, en route to the cruise ship, we're trying to assess the risk. We're talking about how far offshore the cruise ship is, where we're going to hoist from. We're talking about, okay, is this a nighttime hoist or a daytime hoist? Because every hoist can be vastly different from the next. So we're talking about the condition of the patient. Is the patient ambulatory or non-ambulatory? We're talking about how long it's going to take, how much fuel we're going to have once we get on scene, and just trying to assess the overall risk, because any kind of hoist, especially from a cruise ship, is incredibly risky. So we're really trying to take into account all factors while we're en route to the ship. We're always limited by the weight of the aircraft, by the weight of our passengers, and it really limits how much fuel we can take on board, which in turn limits how much time on station we have once we get to the cruise ship and how far offshore we can fly. We are limited with our hoist to a maximum of 600 pounds on the hoist. Generally speaking, what we're looking at doing is taking on a maximum of 2 additional people. Once we get on scene, there are a lot of factors that really play into how long it's going to take us to get the patient off the cruise ship, as well as anybody else that needs to come along, such as the ship's nurse. So things that we consider that could really shave critical time off these hoisting evolutions, things that the cruise ship could really assist us with, is giving us an accurate assessment of the patient, giving us accurate description of the patient's weight and the ship's nurse's weight, whoever else is going to be hoisted up with us, and then making sure that the patient and any other passengers are prepped and ready to go in as close proximity to the hoisting area as possible. So if the ship has everyone ready to go, has the hoisting area clear, we can get in, get out within 20 to 30 minutes on average. We'll identify the best hoisting area through conversations with the cruise ship. Generally speaking, our primary hoisting area is going to be a clear area to the aft of the vessel, clear of any smokestacks. Next up from there would be a nice clear midships position. And aside from that, kind of as a last-ditch effort, a tertiary hoisting area would be a bow hoist, which is a little more difficult. We'll provide the cruise ship with a general hoist brief. It's a standard hoist brief we do for any hoisting situation, independent of the size of the vessel. A standard Coast Guard hoist brief will give directions to the vessel as far as heading, to make sure that we have the best wind over the helicopter, over our rotors, making sure we have the best power available to conduct the hoist. So we'll give the cruise ship a course heading, and also indicate what type of rescue device is to be used. We'll give them instructions to make sure to discharge any static electricity prior to handling the device, and making sure not to connect the hoist cable to anything on the vessel. From that point on, our rescue swimmer will start to prepare the survivor or the patient for hoisting.
We prefer that you don't strap up patients. We have a litter that we use strictly for hoisting, and it's weight tested and it goes through regular maintenance. But it is imperative to have them ready to go, and anyone who is going to be traveling with them, whether it be a nurse or a family member, time is a limitation. Have all their gear ready to go, whether passport, ID, money, medication, whatever it is that they need. For a patient, it can be pretty scary, especially if they're afraid of heights. It's going to be upwards of 150 to 200 foot hoist, and going up in the basket or in the litter, there's a chance you could be spinning because of the wind, things like that. most importantly, just listen to myself, the rescue swimmer. Keep your hands and feet inside and just, hold on tight.